Assalamualaikum and a very good day to everyone. We are from Group 8 representing Haemoglobinopathies and Thalassaemia. This is my team member, and at the end of this topic you will be able to identify the possible blood products to be used in the patient therapy, identify the effect and outcome of each component in patient management, and also able to determine the laboratory tests used in the selecting and monitoring the stem blood component in the patient management. Haemoglobinopathies are inherited disorder that is usually autosomal recessive. The carriers are usually asymptomatic, and hemoglobinopathies have two main categories, which are thalassemia reduced and abnormal hemoglobin A new hemoglobin variant. Thalassemia reduced or absent production of normal alpha or beta globin chains leads to reduced level of hemoglobin A, the main adult hemoglobin. Abnormal hemoglobin A new hemoglobin variant result from the mutation in the genes for alpha or beta globin chains that alter the stability or other function of the hemoglobin molecule. For example, sickle hemoglobin. Types of blood products to be used in a patient therapy are leukoreduced packed red cells, washed red cells, fresh frozen plasma, and leukocytes. Leukoreduced packed red cells is packed red cell with the level of leukocyte reduced to less than 5 times 10 to the power of 6. Leukocyte is harvested from normal donors and may reduce blood requirements and also can prolong the patient lifespan and need less frequent transfusion. The effect and outcome of the blood products in the thalassemia patient. Leukoreduced packed red cells will eliminate adverse reactions that can contribute to contamination of white cells and prevent platelet alloimmunization. Removal of leukocyte from transfused blood cellular products was shown to minimize febrile non-hemolytic reaction, human leukocyte antigen alloimmunization, and platelet refractoriness. It also prevents the transmission of leukotropic viruses, which are cytomegalovirus, human T-cell leukemia virus, and Epstein-Barr virus. New science. It is extension of the intervals between transfusion and also will reduce transfusion of iron overload. It will also reduce the cost of hemochromatosis therapy on the long-term basis. Next is washed red cells. Washed red cells will be beneficial for repeated severe allergic transfusion reactions, and saline washing remove plasma protein in the donor product that are the target for antibodies in the recipient. It performs antibody to IgA in immunoglobulin A deficiency and also result in the adequate leukocyte reduction. For fresh frozen plasma, it will minimize the non-hemolytic febrile transfusion.
The laboratory tests used in selecting and monitoring the blood component in thalassemia patient management. Complete blood count. The complete blood count is an evaluation of the cells in the blood. It evaluates the size and the shape of the red blood cells present, reported as the red cell indices. Mean corpuscular volume (MCV) measures the size of red blood cells. Low MCV is first indication of thalassemia. The red cell distribution width is normal in thalassemia and some occasionally high. Red cell distribution width is used to differentiate between iron deficiency anemia and thalassemia due to microcytic cells. It can result for both diseases. If the RDV level is elevated, we will proceed to the ferritin test, and if the result of ferritin test is normal, it favors thalassemia, but if the result is high, it favors iron deficiency anemia. Next is iron studies. Just now, mentioned that the ferritin test is normal for the thalassemia, and the function of this test is to measure different aspects of the body's iron storage and usage. The tests are also used to determine whether an iron deficiency is the cause of a person's anemia or to help monitor the degree of iron overload in an individual with thalassemia. In thalassemia, the iron level is normal, Therefore, iron therapy will not help people with thalassemia but can cause iron overload which can cause organ damage over time. Blood smear. Blood smear examines a thin layer of blood that is treated with a special stain on a slide under a microscope. The result of thalassemia for blood smear are the size of red blood cells is smaller than the normal, which is microcytic, paler than normal, where it is called hypochromy. So, microcytic hypochromic anemia was diagnosed. The size and shape was varied and cells become nucleated. Therefore, the hemoglobin distribution also is uneven, producing target cells that look like a bull's eye. Hemoglobin electrophoresis. This test assesses the type and relative amounts of hemoglobin present in red blood cells. In adults, hemoglobin A is major constituent followed by hemoglobin 2 and F. Thalassemia disturbs the balance of beta and alpha hemoglobin chain formation and causes an increase in those minor hemoglobin components. So, individuals with the beta thalassemia major usually have larger percentage of hemoglobin F. Those with beta thalassemia minor usually have elevated fraction of hemoglobin A2. Hemoglobin H is a less common form of hemoglobin that may be seen in some cases of alpha thalassemia. DNA analysis. These tests are used to help confirm mutations in the alpha and beta globule producing genes. DNA testing is not routinely done but can be used to help diagnose thalassemia and to determine carrier status. For beta thalassemia, the hemoglobin beta gene, HBB, may be analyzed or sequenced to confirm the presence of thalassemia-causing mutations. Alpha thalassemia detects common mutations such as deletions in the two alpha genes HbA1 and HbA2. Each person has two copies of each of these genes called alleles in their cells, one from their mother and one from their father. These cells govern alpha globin production, and if mutations lead to functional loss of one or more alpha genes, the alpha thalassemia occurs. Laboratory tests of patient management. First, alloantibody screening and identification test. Alloimmunization is a frequent problem that is encountered due to multiple transfusions. Presence of alloantibody can lead hemolytic transfusion reaction or cause the short survival of transfused red cells. This will not help to increase hemoglobin level of thalassemia patients. An alloantibody screen should be performed prior to each transfusion. An alloantibody is an antibody made by the patient against an antigen present on the transfused red cell. If an alloantibody is detected, the specific antibodies causing the transfusion reaction should be determined by the blood bank or by reference laboratory. The management of patients who develop antibodies require use of blood matched by extended red cell antigen phenotype. The second test is cross-matching test or compatibility test. This test is performed prior to each transfusion after antibody screening of the patient's serum. The cross-matching test is carried out for further compatibility testing between donor and patient to determine unexpected alloantibody that is unable to be detected during antibody screening, probably due to low concentration. The third test for patient management is the iron profile test. Iron overload is one of the major complications of regular red blood cell transfusion of thalassemia. Excess iron is deposited in body organs, especially the pancreas, liver, pituitary, and heart, causing fibrosis and eventual organ failure. Bleeding tendency and susceptibility to infection are also related to iron overload. Iron profile tests should be performed after transfusion to monitor the serum iron level of the body. Iron chelation therapy should be given to solve the iron overload, for example using desferrioxamine. The fourth test is bacterial and virus infection test. This test is performed after transfusion. Repeated transfusions increase the risk of blood-borne diseases, including hepatitis B and hepatitis C, although all blood is screened for known blood-borne infections. These are the references that we use to make these slides. So that's all for me. Thank you. That's all for me.